So this is a short screencast on pneumothoraces in relation to the pathology recognition series for the PRP module. Now, a pneumothorax is defined as air that has leaked between the pleura, so it sits within the chest wall cavity, and as you can see, it's defined as this area of air here. Okay, so what normally happens is there's some kind of disruption that means that the air goes through the large airways and then for some reason leaks out and sits in this chest wall cavity. Now, there are a number of different types of pneumothoraces that I'll go into in more detail shortly, but it's important to think about that passage of airflow. So on some occasions, the air can pass in to the pleural space on the breath in, but equally it can pass back out again on the breath out. So there are a number of different types of pneumothorax, and we define them as to really their cause. So there's a spontaneous pneumothorax, traumatic and tension. So the spontaneous pneumothorax occurs spontaneously, but we tend to subcategorise that as to primary or secondary. So a primary spontaneous pneumothorax is one that occurs and there's no underlying respiratory disease that would predispose them to a spontaneous pneumothorax. Secondary spontaneous pneumothorax is due to some kind of respiratory pathology that is likely to have caused that pneumothorax to have occurred in the first place. A traumatic pneumothorax is one that obviously results from a traumatic injury to the chest and often causes a disruption to the pleura, and that could be due to fractured rib, vascular damage, again affecting that pleural membrane. And the other form of pneumothorax that we define is a tension pneumothorax, and this is a pneumothorax that we are very concerned about because your patients can deteriorate very quickly and it can be life-threatening. And the reason the tension pneumothorax is of so much concern is because, whereas we talked about the two-way passage of air before in pneumothoraces, with a tension pneumothorax, what happens is every time someone breathes in, the air goes in, and then for some reason, as the patient breathes out, there is a blockage to that passage of air. So each time there's a breath in, more and more air sits in that pleural space, so that it has a greater effect on the lungs and it generates more and more and more pressure. So as you can see here, what it's defining is this air is generating sufficient pressure to compress the upper lobe, and therefore you're compressing that lung tissue rather than it just deflating because it's not inflating. This is a physical push and compression generated by the air within the pleural cavity. And the reason why we're so concerned about tension pneumothoraces is not only on the ability for gas exchange, but if you generate sufficient pressure within that lung, it will, from the pneumothorax, it will compress the mediastinum and therefore compress the heart, and so you can impact on venous return and ultimately preload and stroke volume. So ultimately, tension pneumothoraces not only present with respiratory symptoms, but they can also present with hemodynamic compromise as well, which is obviously of immediate concern. So in terms of the management of pneumothoraces, if you've got a small spontaneous pneumothorax, usually defined on chest x-ray of less than about 2 centimetres depth from the pleural membrane to the chest wall, and the patient is asymptomatic, so no breathlessness, gas exchange normal, then the patient will be managed in the community with just an outpatient follow-up. If there's a small pneumothorax but the patient is symptomatic, so is breathless or does have respiratory compromise, then they will be admitted and they will be managed accordingly, possibly with an air aspiration, so to remove the air from the chest wall, and maybe further intervention and investigation. So a large spontaneous pneumothorax will result in inpatient management and aspiration and possible insertion of chest drain and other interventions. And obviously a tension pneumothorax must be managed immediately in order to avoid the hemodynamic compromise and the life-threatening situations.